This is the AI challenge that we are confronted with. We have to acknowledge there's liabilities, but let's not miss what's really happening here. Something that's quite extraordinary and unique in our time, and it's just the beginning.
Google releases Bard,
Pausing
its
AI
competitor in the
developments
race
isn't
to
an
make
generative
AI
AI
design.
mission shuttle for
Can
that.
AI treat mental illness?
Hi everybody, it's an absolute pleasure for me to be here today to interview Dr. Eric Topol, who's a cardiologist, one of the world's leading experts on AI in medicine, a researcher and just a prolific author as well. Dr. Topol, thank you so much for your time and joining us today.
Oh, thank you, Allison. It's great to be with you.
I'm sure you are out the door busy given the time it is for AI right now and all of the potential benefits that in medicine. But before we jump into that, I realized after having read a couple of your books and loads of your papers, it occurred to me that I don't really know how you ended up being, like, you're a cardiologist, right? But how you also ended up being one of the world's foremost thought leaders in the role of AI in medicine. What was the journey for you? Were there like key moments that you can recall that sort of fed into that perspective? Because it's really a unique perspective and we're so lucky to have it in the field.
I think it was a natural progression for me. I've always tried to think of where the puck's going or where medicine's headed. And so, back in the late 90s, it was clear that we were starting to accumulate a lot of data. That's when genomics was really taking off, and then we started the sequencing. And then these sensors really were clicking. A smartphone connected to the internet, and '07 with the iPhone. And it was becoming clear that the problem with data was analytics, and the solution was going to be AI. So that's where I had to kind of go into autodidactic mode because I'm not a computer scientist, but I had to hang out with a lot of great ones, like some people you work with, and many others. So that's kind of how I got into it, and it's so exciting. I have to say, as an old dog in medicine, there's no time I can remember that's as exciting as what we're seeing right now with these foundation large language models and how they are inevitably going to transform medicine.
Let's jump in about into the sort of the large language models. And I know that you've written a lot recently on the opportunities for medicine. Could you speak to some of that? Like, do you see additional opportunities now based on specifically LLMs?
Yes, I think what's happened now with these large language or foundation models, generative AI, whatever you want to call it, is we gone from this narrow AI, unimodal, where basically, the charge was just help me with one type of data. And now we are into multimodal, particularly with the GPT-4, which has really been the first one to cross that line. Now it's text and images. And soon will, even go beyond that, of course, as these evolve. So no one in medicine has been able to integrate and process all these layers of data in a given individual, no less in a population. So to be able to have models that will do that and do it, accurately and meaningfully, that's what has been holding us up. So there's so many things out of this multimodal AI, like a virtual health coach that looks holistically, not just at one thing. So, for example, in mental health, what about the interactions with your sleep and your
Right.
physical activity? You have to take data from multiple sources and in real time, being able to really extract the meaning of that data and reflect it back. So this is exciting because we didn't really have a way to do that. And now we haven't done it yet in medicine, but of course, we're on the cusp of being able to.
I think some of the focus has also been on the quality of the data. I think we've come back. I think, 10 years ago, we were all very excited about the potential of big data and then realized it was like a lot of big noise as well. I noticed that recently in a piece in Nature Medicine, you spoke about the sort of the need for annotated, like really well annotated data sets according to phenotype and so on. Could you speak to that, like overall, in terms of kind of data quality and, the potential that data itself has to unlock some of these problems that we have in medicine? Where do you feel? How are you on that sort of spectrum of optimistic, disillusioned?
Yeah, no, this is a great question you're asking. I think what we have to now uh, agree is that each of us is defined by many layers of data, or at least partly defined. And so this multimodal or multi-layered data that defines our uniqueness, it's not only, what is captured in various medical encounters with electronic health records, which is just only a small part of what is about us. It's also things like our genome and our microbiome and our all these other biologic layers, and then our physiome through sensors, our anatome through scans, and environmental, our immunome, our socioeconomic level. So some of those are really high fidelity data, like the genome now is really gotten complete and highly accurate, and even the gut microbiome. Sensors have gotten better and better, but some are still somewhat shaky. Our electronic records are not, there's many sources. People move and the records are cut and pasted largely, 80% of what's in them, lots of errors. So it depends on which layer you're talking about. But overall, the trend is to higher fidelity of the data. And, the charge here is about inputs you're getting at. If the inputs are compromised, if they're incomplete, then the outputs with AI are going to follow suit. And that's the
Right.
problem.
The garbage in, garbage out principle, basically. Yeah, I love that. I mean, you're speaking to so much that is meaningful for us as well, like the basically context, but you're speaking to it in this like multi-dimensional way. We tend to think about data captured in the context of everyday living, which of course is so, and the lived experience, which is so important for behavioral health and mental health, because of course it's that everyday lived experience that in which the problems arise.
I'm really glad you mentioned that because I kind of think of, the mental health story as part of our physiome. That is, we have sensors that can help objectively capture metrics. We're not using them nearly as much as I hope we will in the future to help with subjective things. And, I think that will be another part of the accuracy of data or the completeness of data as we move forward.
I love the phrase that you coined of keyboard liberation. And I think this is the thing, if we can deliver true value to the physician and to the clinical relationship, like that's what I'm really interested in as well. Um, do you see that? Do you see the potential for that in terms of like clinician tooling, apart from just sort of raw kind of insight delivery or information delivery? What other kind of use cases have been knocking around in your head?
Well, the one that I think clinicians will find all of a sudden the endearment, embracement as the keyboard liberation, because over the years since the introduction of electronic records, uh, we were transformed to data clerks. And this is really
Right.
tied into the burnout, disenchantment, and depression that's pretty widespread among clinicians. So to be able to remedy that, where their keyboard use would be de minimis. So the idea is that you would have now being tested in 2,000 doctors at the University of Kansas. They're all done through voice, or whether that's the actual clinic note, whether that's discharge summaries, whether that's operative procedure notes, and on and on. So there's lots of, this is a pluripotent story, but the immediate kind of fantasy is that the clinicians would no longer be data clerks. And we're, of course, just at the starting gate, but it looks like this is going to be a winner. Now, it still means humans in the loop. You have to
Yeah.
review these notes. But the point is, then you can say, I want the note to be in the language and the literacy level of my patient. And I want the note to then lead to nudges to the patient, every X amount of days about the this or that. and you basically can use this format to do things that we can't do. So it goes even beyond just this kind of magical transcription level. It goes to, getting rid of having to say, I want to make the appointment such date out, the prescriptions, the coding, all these functions are just taken away from the menial task of clinicians.
Right. The pre-auth, the idea that just because the way you write a letter for the insurance company can affect whether your patient has to pay out of pocket for care or not. I mean, there's so many, there's so many potential use cases, I think. In the Patient Will See You Now, one of my favorite books, how does this fit with, or like, I know it's very early to say, right? So this is all kind of, we're brainstorming at this point, but do you see immediate use cases or ways in which this maps onto the concept of the empowered patient?
Sure, because we tend to just think about large language models helping clinicians, but in this democratization that we're moving further and further along with, the patients are going to benefit equally or more. And the reason for that is, in fact, in this new book by Peter Lee and colleagues about GPT-4, there's a whole chapter about the empowered patient with the large language models. And I really thought that was important because the idea that you could do so much as a patient when you have this type of ability to prompt. So like just today, there was a paper published about patients asking about breast cancer screening advice, which is obviously a very complicated topic. And this is the first go, but they asked 25 questions. This is the University of Maryland, and they were 88% correct, and only one was inappropriate. And so, to be able to have, instead of having to turn to the doctor, to be able to get some preliminary advice and put your data, not just a Google search which tells you about the general population, but here's my data, GPT X. Now what do I do? And so there's going to be a lot of this. Of course, this is why we need the regulatory oversight, because it has to work well. If it gives bad recommendations, that could be dangerous.
Right, and I feel, and I've written about this too, I feel like one of those dangers is undermining the public confidence because of one or two sort of ill-informed design decisions that, a couple of players have done. So
I come back to, we have to acknowledge there's liabilities, but let's not miss what's really happening here. Something that's quite extraordinary and unique in our time. And it's just the beginning. I think most people, I recently wrote a piece about GPT-X just because we went from ChatGPT in November 30th to GPT-4 released March 14th.
Right.
This is extraordinary. It's so hyper accelerated.
Does Moore's law even apply anymore? I think we're so beyond Moore's law at this point.
Yeah, this is a new law. This is like that was every 18 months. This is like something happening every few weeks. No, this is crazy stuff. But it just means it's going to get better, and we're going to start to weed out the hallucinatory behavior to some extent. It'll never get perfect. And there's still the amplification of bias and lack of fairness and privacy issues that take to another level, of course. So, this is the AI challenge that we are confronted. Just remarkable data ability to analyze, process data, but acknowledging that we don't want to rely ever on machines 100%.
What I'm hearing is very much like this is a tool, and it's going to have limitations, it's going to have benefits, but actually it's a very powerful tool that we owe it to ourselves, the world, and the potential benefit in industry to really lean into the benefit and maximize those. So as a tech optimist, do you see any places where you think that we should not tread with LLM technology or AI more broadly?
Oh, yes. I mean, I think there are concerns that are very legitimate about, the idea that we could make misinformation, disinformation in general much worse, and all the kind of whatever we thought about deep fakes and GANs, we could take to a whole new order of how. So I think this is a big problem. Is we've already seen, particularly in the last few years with the pandemic, the blurring of truth and fact-free, and a movement towards mis and disinformation. And my biggest worry is that we could see that at a new scale. Where we've already seen the beginnings of that, the large language models misused, and I'm worried about that, how it could certainly make things considerably worse. And we're not in a good state right now about that, and that's to me perhaps the number one concern about how this could go in a downside.
I was recently somebody sent me a message that was a screenshot of the front cover of the Daily Mail it was actually from like 1995 or something, pretty late into the 90s, that said, "It's official, the internet is a fad." And like, so I think it's really interesting. I think the way people talk about AI now is the way that people talked about the internet in the 90s. It's the best thing ever. It's, it's so dangerous. And in fact, it's been a tool that has been both of those things. What do you think the media is getting right about LLMs? Like, how do you see that conversation unfolding? Has it been helpful, balanced, unhelpful?
Yeah, it's interesting because there's some that are feeding the pure hype, and some that are, feeding this, 6-month moratorium, which is never going to happen, and, taking a very harsh stance. You don't hear, okay, here's how we're going to take this across the goal line. And that's where we should be putting our efforts, not just, coming up with the design, but also, executing the work, because that's the missing link right now. We got something so powerful, so pluripotent, but you have to prove it. On the clinician side, it has to be very compelling, because a lot of physicians and nurses and pharmacists and all the professionals, they're very leery about this stuff. Not just because they think it's a job threat, which I think most hopefully realize it's not a job threat, but more that, the harm potential is there.
Yeah.
So we have to have compelling evidence that can come from randomized trials. It can come from really well done, rigorous prospective work. But that's what's needed now, is to, even whatever tool we have to work with, get that compelling evidence base out there so that people start to get comfort in becoming, a new standard of care.
Yeah, that's right. We did a survey a few years ago, just sort of testing the general population, the general public's acceptance of kind of digital therapeutics and the field in general, and we found that people are actually very discerning. So they are definitely optimistic and eager to adopt these tools if there is the evidence to support them, and I think that's a very good thing. Because again, I do worry about the undermining of public confidence, where if you have a lack of regulation actually, and it creates and you also have a great need, it creates a big vacuum that gets filled with in some cases just a lot of noise. Everybody's the same claims, everybody's saying the same thing, and over time, in the absence of data, it risks undermining confidence.
And your point is a really important one, because if we have a fiasco because of premature adoption or whatever, it could really hurt the field. It could hurt the progress. It could get stigmatized. So that's why.
That's right.
Hopefully, we all work together to usher this in properly.
And you mentioned in your Nature Medicine piece, you had a sort of call to action for technologists and clinicians to come together and to partner, which is something I really believe in as well. Like, I think as clinicians, we also can't just bury our head in the sand. And also, you want to be at the table with the clinicians developing the technologies. Are there folks that you see doing this well right now?
Well, it's just happening so quickly. I think a lot of groups are trying to, get first mover advantage. We have a paper in Nature about foundation models in medicine, and we like to think that we're, coming up with really good ideas. The group at Harvard, led by Zach Cohane, is certainly, one of the leading groups in the U.S. But there's other groups like Pierce Keane and his colleagues at Moorfields in the U.K., which are doing some amazing things, starting with the retina but also widening that out to the whole body, the gateway, and a good example of this whole idea of foundation models based on, you start with one, the retinal photo, and then you basically start to expand understanding a person and their risk for various conditions. So I think what we're seeing is, different groups around the world. Those are just a few that are really very thoughtful, that are waiting to take these tools, which, as you've already pointed out, are just going to keep getting better, to apply them to prove that this is truly transformative. Which I believe, if there ever was something that fulfilled that descriptor, this is it.
There's doing the work, and then there's helping people more broadly understand the work in the appropriate context. And I mean, I think you've actually done an incredibly amazing job at that through your writing. Actually, a burning question I have is how you have any time for anything else, but that's we can leave that to the end of the interview.
So we have to find the ways to get to people so that they are receptive and eager to learn. But we also we just can't be talking in abstract about excitement.
Right.
We have to actually, in data, in evidence we trust. And that, I think, once we have that, then I think we'll get a lot more receptors open to buy into it.
How important is explainability, do you feel like, in medicine? Or does it
Yeah.
depend on intended use, or what are your thoughts?
Yeah, this has been a highly contested topic, as you well know, Ali. And I tend to side a bit more with the computer scientists here. A lot of things in medicine, we have no idea how they work. I mean, like electroconvulsive therapy for very severe depression. Who knows how that works? But we use it, and we use anesthesia we have no idea how these agents actually work, and lots of things in medicine. So how can we hold machines to a different standard if the validation is really solid, compelling, and even if we can't fully explain it? Now, at the same time, we're getting much better to deconstruct models, reverse engineer to find out, the saliency maps and the features that drive their success or their accuracy. So I think we're going to get to a kind of a steady state where hopefully we'll get validation and we'll also get some explainability. But this also carries through to the large language models because, some people are saying, well, is this really artificial general intelligence? Well, it doesn't really matter what it is. If it's working, if it helps us, we'll take it. We'll take it. Yeah.
Given that perspective, I wonder, I know you mentioned it earlier, what do you think about this letter that was written to sort of say we should pause for 6 months? And similarly, I'm thinking about I think the Italian government has implemented a ban.
This is really crazy stuff because we're not going to have any ban. It's not going to happen. And this is a race now that's, got enormous commercial interests, not just the tech titans between Microsoft and Google, but far bigger than that. And it's also, the fact that it has so much benefit that's incubating. We don't want to suppress that. But we do need to figure out ways to authenticate that is, when you have, the Pope wearing some down jacket, and that's not right, there should be an immediate signal that this is fake. And we haven't done that yet. That is to basically use AI to determine whether something's genuine. And that's something we have to work on. But no, it's really the idea that we could somehow put this on ice for 6 months or a year indefinitely. It's absurd. It's never going to happen. So, it might sound good to certain people that are worried, and I'm worried too. When you say optimist, it doesn't mean that you have, blind eye towards where it can go wrong, right? And so I'm hoping that we'll have efforts to use, the funny thing about AI scientists is they think that every problem with AI solution uses AI, but it doesn't necessarily true. But maybe here, that is what's genuine, what is
Yeah.
actually done properly, what is basically fabricated. We've got to have a handle on that.
I absolutely agree. And it was really interesting in the pandemic. One of the lessons for me, at least, was how quickly things can change if you have political will. Um, I- so what is the role of government here? Is it regulation?
We don't prevent the progress, but we have guardrails. Um, and I think that coming up with that right balance, we haven't done that yet. Even with AI being narrow and unimodal, we still haven't figured out how to exploit the autodidactic function. You know, the algorithms
Yes.
were frozen. The day they get approved, if you could let them loose and just keep getting better and better, but the way we've handled, unimodal AI, like for example, radiology scans, it's really hurt the power. We've diminished the remarkable power. So we haven't yet found that balance, Ali. That is, we haven't figured out how to do it.
Eroding the model over time ultimately is not in patients' best interest.
Right,
So,
right.
Eric, you must have a front seat here. What's going on? Why haven't we been able to figure out how to regulate sensibly?
Well, yeah, it gives me fits just because we haven't really yet figured out how to derive maximal benefit, and minimize risk. I'm hoping that the lessons we've learned so far with largely images, which has been the sweet spot for
Yeah.
medicine now for the last few years, that the shortcomings will not repeat itself. That we will take advantage of that. The more data that goes into models, the more tokens, the better parameters, and also that we acknowledge that this is dynamic. That
Yeah.
you can't just approve, a GPTX that day and then not let any further inputs be incorporated. So I do hope that we'll figure this out. Regulatory bodies throughout the world tend to be very conservative, and they are aware of the power, and they are more afraid of it. We have to come up with the right balance, and we haven't gotten there yet.
That's right. I've heard that people argue that it actually comes back to the Hippocratic Oath, that the do no harm has sort of created the environment such that we're so afraid of harm. Whereas if the Hippocratic Oath could have been more like do good, that
Yeah,
it was
yeah.
actually it's more suited for our modern times and modern medicine. And now we're sort of in this place where we're really stuck. Because and it's so I do the overall, I think, position of like the net benefit to the patient is the correct one, but it just seems to we seem to over anchor on this like large fear of any risk whatsoever, whereas the truth is that lots of human delivered services are associated they are all associated with risk because we are humans and humans are human.
I'm so glad you mentioned that. There is a lot of unintended harm that's done in the human to human connects. And so if we were to come up with a new oath, it would be maximize net benefit, and
Yes.
um, because fixating on harm is what holds us back. There is no such thing as any intervention, medication, device, diagnostic test that's 100% foolproof. So acknowledging that, so that we're not stymied and don't hold back from the progress that lies ahead. That's really important.
I totally agree, and it's a balanced approach. It's the only way to move forward with actual balance rather than polarization. Because I feel I think when you're involved in creating something that is relatively new or uses new technology, if there is sort of one place where it doesn't work in this completely optimized way, it's sort of held up as, aha, you see, there you go,
Yeah,
evidence of harm. And
exactly.
it's just so overall, it's so damaging when you look at the overall sort of picture and the overall potential and actually, actual realized benefit as well. Coming to the end, we always ask everybody that we interview as well this one question, that if you could change anything in the way that healthcare is delivered today, what would it be? And I'm going to suggest that you would probably say everything, but or a lot of it.
Yeah, yeah.
But if you had to choose
Uh,
the number one,
it depends on what time frame you're asking. So,
oh,
like
brilliant! I
right
love this.
now,
Break it
I
down for
I
us.
would say, just liberate the damn keyboards and get the gift of time for patients and patient-doctor relations to be restored. But if you say, what do I want in 5 years? I want to get rid of hospital rooms, and only hospitals become, the place where you ICU and emergency rooms, operating rooms. But the regular hospital room has become obsolete in the next 5 to 10 years because we have the ability to do that, and we should be doing it. So, it kind of right now there's an immediate thing I'd want to see, which is let's get gift of time, let's get patient autonomy going. That the ability for doctorless screening of all the common conditions that are not life-threatening, skin lesions and cancer and urinary tract infections and ear infections in children, and the list goes on and on. Let's get this stuff where, and obviously that extends to mental health as well, to support people. But I do think it's, the power and the willingness to validate things as we get more and more bold and capable over time. So the answer to the question for me is it's just a matter of time.
I love that dimension of time. That is incredible. I completely agree with you as well. We often talk about how the sort of the architecture of clinical services and therapy in general actually accidentally, not intentionally, but often inadvertently undermines the patient's ability to engage in a therapeutic process. Dr. Topol, thank you so much for your time and joining us today.
Oh, thank you, Allison. It's great to be with you.